Was a pleasure to work on frailty and multimorbidity because it's what I do every day, so it's not far away from what I do. I think it's the best thing to do. And just the context to explain, it's we have to change the way we view and talk about frailty. That's the context, because actually the approach to frailty is negative from patient and healthy and the public health perspective. And is focusing on glass self-empty, so the elevated risk, vulnerability, but proxy to the end of the life, rather than the half-full reversible condition and a potential therapeutic target. Negative approach is not surprising, since the Oxford English Dictionary defines frailty as fault and infirmity at the physical, psychological level. Second. So we have to identify the red zone, not in a bad way, but in a good way. Frail is reversible. It's different from robust. It is a healthy aging trajectory. And it's different than disability, which is dependency and the people that reach very early during the life course the onset of disability. So we cannot wait after everything is happening. That's a matrice after the earthquake. We have to focus on the pre-disability, even though that frailty is considered low priority issue too early or too late, according to the division. Not enough clinical relevant. Education is important in this sense. No easy to use tools are able to detect, and the action are very expensive. But when the frailty is translating into disability, the priority is high. Yeah, the tools are efficient, but the phenomenon is too late. The expensive is very, very expensive as a phenomenon. So that's the population not autosufficient in Italy. So if you see, it's correspond to the entire city of Rome in 2015. So we have more than 2,500,000 people, citizens, not autosufficient in Italy. Okay? So we have to bridging the gap. We have the public vision, and we have the private vision, and we have the scientific vision. That's why, that's our fault. From geriatrician point of view, we were not able to translate this important concept in the public health problem. We have another problem, is confusion. It's the overlapping between frailty, multimorbidity, and disability. We have to just to make a choice, considering there is overlapping between frailty and multimorbidity. But as you can see in the B figure, both frailty and multimorbidity can lead to disability. So we need to identify these two conditions together in order to prevent disability. So we need to take away the concept of disability, and we have to focus on frailty and multimorbidity in order to select the simple tools by multi-professional to create an hospital territory platform community platform, in order to start proactive intervention and prevent disability. That's the state of art of current tools using for detecting frailty and multimorbidity. Not easy. Majority is addressing disability rather than frailty and multimorbidity. They are time consuming. They have a complex core, but much more important, they do not translate in proactive intervention. So a group of experts, a Sunfrail Consortium, based on public health expertise, geriatric medicine, sociology, after revision of the literature, good practice, a selection single items of existing instruments, we create this Sunfrail tool already addressed by physical, neuropsychological domain, number 6 and 7, and number 8 and 9 or 2 of items focusing on socioeconomics frailty. So if you can see, it's the population target is basically in the community, but also can address the outpatient. And the way we address the concept of multimorbidity is based on 5 or more medications per day, because exactly the proxy of multimorbidity, even a stronger concept, because 5 or more medication means that you can have more than 2 or 3 chronic disease. At the same time, the way the older person they have to take care of the medication is also an extremely important effort. So that's the target of the population, the context of community older subject, outpatient, with higher level of education, living in urban and rural areas, not institutionalized, not presenting physical mental disability, capable to understand the questionnaire. So who is going to administer the Sunfrail Tool? Where? It's a different professional. That's the way we proceed. Not only medical doctors or primary care physicians, but also social workers, community nurses, community actors and caregivers, even students in medicine, nursing, other disciplines. Where? The setting is a primary health, social care, community setting, and also in the hospital during outpatient routinary visit. The tool has been translated and back translated by native speakers from English into 4 languages, Italian, French, Polish, and Spanish, as is in the way to be translated in German. We verify the adaptability, understandability, and comprehensibility of Sunfrail Tool, and also the potential application in the current professional practice. Each item question was tested the score ambiguous, understandable, not understandable for each potential option. That's the profession are going to address the specific tool, and we create, as already addressed, a flow chart with the activation of specific care pathways in a number of at least 100 beneficiaries for each reference site. Okay? So we verify the applicability, so to say if the instrument is suitable to identify the domains of frailty and to activate care pathways. Okay? That's the instrument. Okay? So I want to stress, I want to show a very easy and probably good example. If we have a positivity, for example, for physical and neuropsychological domain, what we can do to confirm the alert that is generated by the tool or the instrument? So we need to do very easy to use objective performance test in order to activate the pathways. Okay. So one example is if you have an alert in physical cognitive domain, and you use a very easy to use objective tests such as hand grip strength or gait speed, or cognitive, mini mental state examination, GP-COG for cognitive domain, we know we can activate physical exercise because physical exercise is an intervention. Intervention has been recognized very efficient instrument and effort and also instrument to reduce mobility disability after 2 years. That's the live study. So that's what we did. We apply the Sunfrail tool in the SPRINT-T. It's an ongoing multi-center trials where University of Parma in Emilia-Romagna region is part of that, using exercise, nutrition, and technology. This is an ongoing trial. We use that is going to test the effect of multi-component intervention, such as exercise, nutrition intervention, and also technology in order to prevent disability. That's the inclusion criteria, also informed consent, subject of both sexes and older than 70 years, with a very easy to use instrument to assess physical frailty. The people should be able to walk for 400 meters with low muscle mass. And that's the primary outcome, mobility disability, in order to inability to complete the 400-meter walking test. So that's what we apply the Sunfrail tool. And that's a preliminary data for SPRINT-T screening. We address evaluating more than 200 people with a mean age 81, mean mental state examination about 21st, 4-meter walking speed about 0.59. That's the old measure, with a majority of male and female and a minority of male, as expected. What we saw that the majority of these people had the difficulties in memory decline, just outpatient, so we don't know before this patient. So we had memory decline, they refer walking less, and also they report also the falls. So that's the mainly, and also you can see 60% of these participants had the polypharmacotherapy. So this is what we did. If you report memory decline, and you do a performance test very easy to use, such as mini mental state examination, the positivity in memory decline is confirmed by objective test, and that's what we found. People that report to have memory decline have a lower mini mental status examination than other people, with the P of statistical significance independent of age or sex. If you report false, what about your walking speed? And the walking speed is reported to be higher in people that do not report false, and also the hand grip strength is even higher in this subsection. People that report to walking less because of the physical status, they have a lower gait speed. And that's the team. It's a multi-professional. We talk about integrate care. The team that is working on the sprint team, but it could be a potential team of every reference site composed by medical doctor, by physiotherapist, by nurse, expert in community, by dietitian, expert in technology, and other professional figures useful to address multimorbidity and frailty in a community and outpatient clinical visit. Thank you.